So Dr. Sanjeev, he's the Principal Director and Head Hepatology of Liver Transplant in Max Hospital in Saket, New Delhi. And he has been spearheaded the medical team of liver transplantation in one of the largest liver transplant programs in India for over 18 years, and over 3,400 liver transplants, over 125 indexed publications. So he has won the National Fighter Awards, and he's a member of AASLD and APASO, INASO, and ISG. He is also the founder member of the Liver Transplantation Society of India. So Dr. Sanjeev, I'd like to give the host to you tonight.
Thank you, Lai. Thank you very much for this warm introduction. And I am indeed privileged to be moderating this session today. This is a very interesting topic, clinical guidance for portal hypertension. And when you offered this to me, I was wondering how it will be. So I presume that this will be an interesting session today with two very important topics, which are a mix of basic sciences as well as clinical application of that. And we'll have two very young, eminent speakers for this. I'll introduce the speakers first. We have, for the first talk, we have Dr. Mithun Sharma. He's a dear friend who's Director of Hepatology and Regenerative Medicine and Liver Transplantation at the Asian Institute of Gastroenterology and AIG Hospitals, Hyderabad. Numerous publications, very dynamic doctor who's been, in the academic circle and clinical circle right through, member of various organizations, including the ASLD, EASL, AGA, ACG, etc. Now, Dr. Mithun would be presenting his talk first, which would be on clinical guidance for portal hypertension, LSM Beveno 7 based application. And then we will have the next talk by Dr. Hemlatha. Dr. Hemlatha Elango. She is a transplant hepatologist, a founder, director at the Liver World, senior consultant hepatologist and liver transplant physician at Mayotte Hospitals in Chennai. Specializes in management of fatty liver, cirrhosis, decompensated liver disease, viral hepatitis, liver transplant. Has a special interest in ICU care of critically ill cirrhotic patients, acute and chronic liver failure, perioperative management of liver transplant patients, and preventive hepatology, member of ASLD, ISG, IAS, CCM, and so on. So, and she's going to be speaking on the next talk, which would be on, LSM, ultrasound attenuated parameter, and the evolution of, subclinical portal hypertension in non-cirrhotic NFLD, a difficult topic, I must say. So I think that we will, if you permit, we will move on to the first talk by Dr. Mithun Sharma, and I would invite him to share his presentation and start the session for today.
Thank you, Dr. Sanjeev and Lee, for giving us this opportunity to speak today on a topic which is not very frequently discussed. Is my screen on this one on full screen? Yeah. So I'll be talking on the Beveno 7 consensus, which has been recently concluded around 5-6 months back, and what is the role of LSM based on this consensus statement. So when I was giving this talk, I thought that let us outline our discussion based on what are the non-invasive fibrosis assessment tools that we use in our day-to-day practice. We are very much used to FibroScan. So FibroTouch was something new for us because we don't, to be honest, have it in our center. So I thought let us review the literature of FibroScan versus FibroTouch. And what is the need of doing a FibroScan or a FibroTouch based LSM assessment in portal hypertension and variceal assessment? What does the guidelines tell about it? And a critical analysis of the same, and finally some take-home messages. So we all know that when we talk of cirrhosis of liver, portal hypertension is the key. Portal hypertension is responsible for varices. Portal hypertension is responsible for development of ascites. Portal hypertension is responsible for development of hepatic encephalopathy. So why not target this main thing which causes all the side effects of liver cirrhosis. So when you talk about portal hypertension, we use two terminologies. One is called clinically significant portal hypertension, and one is preclinical portal hypertension or subclinical portal hypertension, which I'm looking forward to hearing the next talk, which will be very interesting. So clinically significant portal hypertension is defined when there is a portal pressure as measured by HVPG, which was considered to be gold standard, of above 10, or when we have clinical manifestation of the disease like esophageal varices and ascites due to portal hypertension. Preclinical portal hypertension is when the portal pressure is between 5 to 9. And it usually correlates with disease severity. We have clinically significant portal hypertension in 40% of child A cirrhotic patients. And by the time they become child C, around 85% of them have it. So the new Baveno 7 feels that whenever the HbPG is more than 5, we should think of more of sinusoidal hypertension. And this new terminology, when the portal hypertension between 5 to 9 is being used, is a compensated advanced chronic liver disease. So in our clinical practice, we normally all use some non-invasive test for fibrosis assessment. It may not be the same test that we all agree, but we at least use one of them. The most common is the AST to platelet ratio and the FIPS score that is being used at our center. There is obviously tests like the Enhanced Liver Fibrosis Panel, the BAR score, and the NAFL fibrosis score, which takes into account the fasting hyperglycemia as well as the age of the patient and the ratio of AST, ALT, and platelets. However, none of these tests are perfect. There are some gray zones where these tests cannot pick up the fibrosis. It can definitely tell us no fibrosis or definite fibrosis. But what we really find in clinical practice is the gray zone remains gray. So treating portal hypertension may be the key. It is believed that if we can prevent the portal pressure gradient from exceeding above 10, we may be able to prevent all the complications of portal hypertension and decompensation of cirrhosis. Also, we all know that variceal bleeding and ascites, if ever occur until the portal gradient is above 12, indicating that there should be a level which we should strive to keep the side effects of portal hypertension at bay. But to measure SBPG repeatedly outside or even inside an academic institute is very difficult. Some people argue that why don't you measure portal pressure by HbPG every time? Because you don't treat blood pressure without checking the BP. But it's not as simple. It's an invasive procedure. So non-invasive test for fibrosis, the commonest that we use in our clinical practice is the FibroScan, and now we have the FibroTouch. So the majority of experience in India is possibly with a FibroScan with a grossly evolving literature on FibroTouch. So I thought that why not see how does these two machines compare before we decide on which is better or whether they are equivocal. I'll come to that in the next slide. There are other invasive tools. We have ARFI, which is an ultrasound based. Then many people get a CT scan, but this is hardly done to assess fibrosis or steatosis unless we use it very frequently in liver transplant donors, where we're getting a CT scan and we see the liver attenuation index. And then obviously there are some MRI based modules which can detect fibrosis. And these are mostly used in patients where our FibroScan machine is not able to give a result, or we have a very obese patient. The MR-based methods are now considered to be almost gold standard, and data are emerging that it is almost equivocal results with a liver biopsy. The MRI-based methods could be an MR spectrography or an MR PDFF or an MR elastography, which is considered to be the best of the three. So getting a privilege to work in a center where we have all these modalities, practically the most commonly that we use is the LSM based on the FibroScan. So let us see, this is a study on around 211 patients of chronic hepatitis B, where these patients underwent a fibroscan as well as an LSM evaluation by a fibrotouch machine. So the results of successful detection was around 100% for fibrotouch. These were obviously non-obese patients, and was around 97% for the fibroscan. There was no statistically significant difference between the LSM values that were obtained by both the machines. And it was concluded that both these machines have a good consistency in evaluation of degree of liver fibrosis in this subset of patients of chronic hepatitis B. This is another study where they tried to use the attenuation parameter and liver stiffness of both these machines in patients with a chronic liver disease. And if you see this image on the left-hand side, this is the mean of the values obtained by FibroScan, which is in red color, and the blue are the ones which are obtained with the FibroTouch machine. And there was a very good intra-class correlation between the LSM values obtained by both these machines. Similarly, if we see the CAP score, the attenuation parameters, which assesses the degree of steatosis, there was also a significant overlap between both the results of both the machines. So there was nothing to choose between the same. What was found that the FibroTouch had a shorter examination time of around 33 seconds. This is the acquisition time when compared to a FibroScan machine. But this doesn't translate much into clinical parameters, because as a clinician, what I want is that the value should be accurate. This was another study where they compared FibroTouch with FibroScan in patients with chronic liver disease. So these patients, around 400 plus patients, underwent examinations by FibroScan, FibroTouch, as well as other non-invasive tests like APRI and the FIPS score, and they had a reference liver biopsy. So the area under curve of both FibroTouch and FibroScans were similar for significant fibrosis and cirrhosis. The area under curve of FibroTouch was higher than APRI and FIB4, but similar to that of the FibroScan machine. So when we talk about two machines and two modalities, we always check for the correlation, and the correlation was pretty good. It was a significantly good correlation between both the machines. Then the diagnostic accuracy for identifying significant fibrosis, severe fibrosis, and cirrhosis was progressively increasing, 73.3% for significant fibrosis, 83.2% for severe fibrosis, and around 85% for cirrhosis. And these data were comparable in both the machines. So this concludes the first part of the talk, that yes, we use some non-invasive methods for assessment of fibrosis based on which machine we have, whether it's a FibroScan or FibroTouch. The existing literature says that there is not much difference or much to choose between either of them. The next part of the talk will be on the need for use of LSM in portal hypertension, and what does the Baveno 7 guidelines talk about it. So for people here, the Baveno 7 consensus was initially planned last year, but it was postponed due to COVID, and it was held in October. It discussed 9 relevant points related to portal hypertension. But what was important to us was the use of non-invasive tools for diagnosis of compensated advanced chronic liver disease and clinically significant portal hypertension. So out of these 9 points that were discussed, it's a long consensus. We will concentrate only on this point today. So when we talk of LSM, the Baveno 7 has combined the platelet count along with it. And it's basically a juggling of numbers, which people have to realize and keep in mind, or we can keep a play card in front of us to remember these numbers, which we get used to it. And it all depends on what the value of the LSM and platelet is to diagnose whether these patients will have esophageal varices or clinically significant portal hypertension. So these are some of the definitions or the comparative that have been done in the Baveno 7. The HVPG, if it is more than 5, it is called as subclinical portal hypertension. And they more specifically say that you should suspect sinusoidal portal hypertension. Then HVPG of greater than or equal to 10 is basically clinically significant portal hypertension. This has been mostly validated in patients with alcohol-related cirrhosis and viral etiologies. What is very important is that patients of non-alcoholic steatohepatitis may have an HVPG of less than 10, but yet they may be having clinically significant portal hypertension. So this is something which is new and needs to be kept in mind. And if we have a patient which has an HVPG of below 10, but has varices, ascites, and portosystemic collaterals, then it means that portosystemic vascular disorders must be ruled out. So clinical significant portal hypertension, either by HVPG or with the clinical manifestation of portal hypertension, would lead to a higher risk of decompensation, mortality in patients with cirrhosis if they are supposed to go for a surgery for a hepatocellular carcinoma. Similarly, it is important to know these pressures because if the HVPG is above 16, for any type of abdominal surgery, which is non-hepatic, there will be an increased risk of short-term mortality. But can we do an HVPG before every surgery we do is something which not everyone has the capacity to do it or the ability to do it or is required to be done. So this new terminologies that has been brought for compensated advanced chronic liver disease. So here we need to concentrate that if the transient elastography value is less than 10, and there is no other clinical or imaging signs of portal hypertension, this will practically rule out compensated advanced chronic liver disease. A FibroScan value of between 10 to 15 usually suggests a compensated advanced chronic liver disease. And if it is above 15, the word that has been used is that it will highly be suggestive of a compensated advanced chronic liver disease. So patients with chronic liver disease and an LSM of less than 10 have a less than 1% risk of decompensation and liver-related death. On the other hand, LSM values, irrespective of the technique used for measurement, will hold this prognostic information both at the indexed investigation and the Baveno feels the same thing should be done on a follow-up basis. And they have suggested a rule of 5. These values are 10, 15, 20, 25. It denotes progressively higher relative risk of decompensation and liver-related death independent of the etiology of liver cirrhosis. So I have tabulated this in a tabular form. So it says that if the KPA value is between 7 to 10, these patients did not get an endoscopy. They can be monitored on a case-to-case basis. And if they progress to a compensated advanced chronic liver disease, that is the KPA increases between 10 to 15, then the chances of getting clinically significant portal hypertension will increase. If the index LSM value is found to be 10 in any patient, we should try to find out whether we have done the test properly. They should be retested in a fasting and can be supplemented by additional tests like the fibro test or fibrosis panel that we use. Any of the tests should be used and they should be supplemented to diagnose significant portal hypertension. Now, if the patient has developed clinically compensated advanced chronic liver disease, that is the KPA value has gone to more than 10, but they have no other signs, they should be monitored every 12 months by LSM measurement to monitor the changes. And if any point of time, we are not only talking about LSM increase, sometimes the LSM can decrease. A decrease in LSM by more than 20% or which is associated with an LSM value of less than 20 kilopascal, or any decrease to below 10 significantly decreases the risk of decompensation and liver-related deaths. Now, can we identify clinically significant portal hypertension by transient elastography, and how do we translate it into our clinical practice? So here we combine two parameters, that is the transient elastography value and the platelet count. So if the transient elastography value is less than 15 kilopascal and the platelet count is greater than 1.5 lakh, then it rules out clinically significant portal hypertension with a sensitivity and a negative predictive value of above 90%. For viral, alcohol-related, or non-obese NASH, if an LSM is more than 25, it will practically rule in clinically significant portal hypertension with a specificity and a positive predictive value of more than 90%. And these patients, if undergoes endoscopy, will surely have endoscopic signs of portal hypertension, and they are at very high risk of decompensation. For viral or alcohol-related non-obese NAFL patients, now if the LSM increases to 20 to 25 and the platelet is less than 1.5 lakhs, or if we have a value of 15 to 20 and a lower platelet count of less than 110, it will mean that there will be clinically significant portal hypertension in 60% of cases. Also, the Baveno recommends that in machines which are compatible to do with a spleen stiffness measurement, if it is less than 21 kilopascals, it again rules out clinically significant portal hypertension. Anything above 50 will rule in clinically significant portal hypertension. So there are a lot of values here which we can use to find out whether these patients are having a clinically significant portal hypertension and in signs of endoscopic varices. So for detection of varices, there are few studies. Most of them are retrospective, so I did not include, but there is one meta-analysis which says they've compared LSM with the spleen stiffness involving around 4,000 patients. But whatever method we use and whatever permutation and combination we are using for detection of esophageal varices, it can detect in only 70%. So at this point, LSM is not for detection of varices, but yes, it can detect if the LSM values are high, above 25 or above 20 with a low platelet count. It can identify those varices that may have a significant risk of bleeding. So this is another study where LSM was used to identify different grades of varices. So these were again hepatitis B patients undergoing endoscopy for esophageal varices. And paradoxically, they were subjected to a FibroTouch. And it was found that as the value of the LSM increases, at 12.6, there was very less risk of varices. At around 19, it was more of less of grade 2 esophageal varices. At this, it will be less than grade 3. And at a certain level, there will be, it cannot correlate with the risk of esophageal bleeding, but there was definitely a correlation with the risk of esophageal varices grade. And the area under curve and the sensitivity and the specificity was quite good, of around 90 plus. So can we use LSM and esophageal varices and do away with screening endoscopy? I feel it's too early to give a comment on this, but what it feels that if an LSM is more than 20 or a platelet count is less than 1.5 lakhs, these patients definitely still need an endoscopy for a variceal screen. In patients who wants to avoid an endoscopy or where we can't do an endoscopy because of other comorbidities, follow-up of yearly LSM and platelet count may suffice. If the elastography value is above 20 or the platelet count is above below 1.5, try to somehow get an endoscopy done. However, if the TEE is below 20 or platelets are above 1.5, we may just do away with it and monitor them by an LSM. On the other hand, if we do a spleen stiffness of less than 40 it will identify a group of patients with a low probability of high-risk varices, in whom again endoscopy can be avoided. Now, most of these guidelines, to be precise, are from the Western countries where endoscopy is very costly. But I work in a center where endoscopy is cheaper than fibroscan. So to translate this into my clinical practice is a little difficult. So coming to LSM in management of portal hypertension. So in patients with hepatitis C related compensated advanced chronic liver disease who have attained a sustained virological response, a consistent post-treatment LSM value, if it is below 12 and persistently the platelet count is coming above 1.5, these patients can be discharged from portal hypertension surveillance, that is LSM and endoscopy, and they have a negligible risk of decompensation. Similarly, for patients with hepatitis B who had a good viral suppression, an ACV with the SVR12, again, if the LSM is below 20 and platelet is above 1.5, this will rule out high-risk varices. And patients who are a non-selective beta blocker without any significant portal hypertension, that is LSM is less than 25, we may try to relook an endoscopy in 1 to 2 years. And if there are no varices, then it can also be an indication for decontinuation of beta blockers. So these are the suggestions given by the Baveno 7, but this may not be practically applicable. So this is finally the rule of 5. So anything below 5 is normal, and it excludes compensated advanced chronic liver disease. Values between 10 to 15 kilopascal suggests a compensated advanced chronic liver disease. Combined with this, if the platelet count is more than or equal to 1.5, it excludes clinically significant portal hypertension. If it is greater than 1.5, the guidelines said to avoid endoscopy. If it is anything between 15 to 25, between 15 to 10, you assume it as clinically compensated advanced chronic liver disease. And if it is anything above 25, you have to presume that this has clinically significant portal hypertension in viral, alcohol, and non-obese NASH. And these are the patients where the chances of decompensation, finding an esophageal varices are very high. So you should also keep in mind that if the LSM decreases, there is a new terminology, which is very interesting, which is called recompensation. That is, if you can remove the cause of cirrhosis, like in Hep C or Hep B, if there is resolution of ascites of diuretics, if there is no encephalopathy, and if there is absence of any recurrent variceal hemorrhage in 12 months, and they have a stable liver function, the consensus guideline feels we can use the terminology of a recompensated chronic liver disease. So we have seen in the last 20 minutes or so the role of LSM in management of portal hypertension. So portal hypertension management is the key. Though HVPG is the gold standard, yet transient elastography can be used as an effective alternative in centers where we cannot do HVPG routinely. The Baveno 7 identifies a distinct role of transient elastography in diagnosis of clinically significant portal hypertension, as well as identifying a group for screening endoscopy and monitoring them for clinically significant portal hypertension. And if there is a decrease in the KPA value, some of them can be off the radar. Routine use of transient elastography by any method, whichever machine we use, whether it's a FibroScan, FibroTouch, ARFI, or MRI, it is recommended to use some methods so that we can treat these patients and monitor these patients better. And as the guidelines mentioned, possibly in future, there will be a personalized care of portal hypertension based on the level of their HVPG or the transient elastography values. And this will be a very good approach in management of these patients. With this, I would be thankful to you, but what we remember is that it's a delicate balance which measures. We cannot do away with endoscopy. We cannot survive only with LSM. HVPG still holds the key in management of these patients, are giving us the actual value, is still the gold standard. So this balance needs to be maintained. Each of them can be complementary to each other rather than be competitor to one another. Thank you so much for your patient hearing. Would be happy to take any questions that may be there. Thank you.
Thank you, Mithun. That was very nice and very well presented. I liked your last slide very much. There has to be a balance in whatever we do. Tell me one thing. See, I mean, there are many things which we can discuss as clinicians, but first thing which I would like to ask you is, in your patient management protocol, when you see patient, in that algorithm, at what stage you order the fibroscan or fibrotest LSM thing? You have you do the blood test, you viral markers, you do ultrasound, CT, MRI, so on. So at what stage, when you suspect a cirrhotic, does this LSM thing come in your algorithm?
So practically speaking, the LSM thing comes in two major clinical scenario. When somebody comes to my clinic with an ultrasound report and the radiologist has first written mildly subtle coarse ecotexture of the liver, where I know that neither the radiologist is sure of what he is writing, neither am I sure that I'm ruling out fibrosis. So those are the patients where the fibroscan sometimes can be very helpful, when I can rule in or rule out a fibrosis. But again, sometimes we'll end up in a gray zone with a 10 or 11 value, and then we are trapped. The second thing is that in monitoring the patient, sometimes we use fibroscan. First, these patients demand it. They have a strong feeling that lower the value is better, higher is worse. Initially, we thought they were wrong, but now we realize they are correct, because at least a high LSM value can predict the development of hepatocellular carcinoma. And also, as we see, anything above 25 possibly has varices. But at the center, we do endoscopy more commonly than we do fibroscan. So we hardly rely in our clinical algorithm. I never see my LSM value and think, oh, this patient will have a varices. But yes, the science of it is that comes, but practically detection of varices is still by a screening endoscopy.
Yeah, I mean, exactly. I mean, that was what I thought, I mean, people, I mean, you and me, we are in setups where endoscopy is a bread and butter, and we are tuned to that.
Yeah. Yeah.
So what happens is, when somebody has got an established cirrhotic, report carrying in my OPD with a CT or MR, whatever it is, generally, till now, the practice has been that, you can skip fibroscan, to be honest.
Yeah, that's
because
what
you're not doing fibroscan to decide for endoscopy. You are pretty much sure that you'll do an endoscopy if patient has got cirrhotic liver. But this is a very interesting Bevanno classification, and I think a very useful guideline, and I think it needs to be looked at. And your point is very well taken that endoscopy is easily available, cost issue is not much. But nevertheless, I think it's an evolving science, and we must look into that very carefully. And this may really, change the practice which we do as of now. One other thing which I always find it, difficult to understand. This again from Western data. I don't know what you feel, but in my patients, I feel platelets. I don't find them, 2.5 lakh platelets. Invariably in my cirrhotics, especially in alcoholics, they have nutritional deficiencies. They have megaloblastic picture. The platelets are already, 1.2 lakh, 80,000 or so. So, but if you look at the Bevanno classification, platelets are given huge importance, 150 as a cutoff. I mean, I somehow feel that if I start using this cutoff, I mean, in all my patients, I'll just go wrong. It appears to me, I don't know. So how would you, feel about, using platelets of 150 as a cutoff for inclusion or exclusion of your algorithm, which we have discussed in Bevanno classification?
So I extremely agree with you this point. So I come from a part of the country, I come from Assam. So in Assam, if you go check our platelet counts, my own platelet count is 1.2 lakhs if I do a machine reading. So why it is low? Because people from the eastern part of the country, a lot of publications on this, they have giant platelets. So when they are put in this auto analyzer for CBC, they count them as RBCs. And the platelet count invariably comes as 1.2 lakhs, 1.1 lakhs, or 90,000. And when you do a manual count, which is not practically possible for all the patients to be done, considering the volume, the value comes a little higher. But yes, I hardly see patients with platelet counts of above 1.5 or 150 in my clinical practice. So to my eye, a platelet count of 70, 80 looks quite normal, because that is what we keep on seeing in our cirrhotic patients. So sometimes somebody asks me why the platelet is low. I said, oh, is it low? So it did not catch my eye also. So that is what we are normally used to. So I think we need a validation of this Baveno 7 in an Indian cohort of patients, and then see what our platelet count is. I agree to that point totally.
Yeah, I mean, so that is what I'm trying to understand, that, we have excellent guidelines,
Yeah,
but we have to see, are these applicable in a unmodified way in our own patients?
right.
And many times I've seen that the guidelines are very good. They sound extremely good to read and understand.
Yeah.
But in clinical practice, I find it very difficult. Even in my liver transplant donors, I've seen these healthy people, they have 1.3, 1.4 platelets.
Yeah.
And surgeon says, "Arey, chodo yaar, let's go ahead." That's the problem. And I mean, you can say the social status and the demographics which impact a lot of things. I have one more question to you, which is, in fact, two of them actually.
Yeah.
There is a mention which you did in passing in one of the slides, mentioned that LSM can guide the need of varicose banding. It's in that table.
Yeah.
I am not sure till, as of now, we've been practicing gastroenterology and endoscopy. We have clinical science in our mind. We know when to do banding. You do endoscopy, and so very important point. Will LSM help you in deciding whether a patient needs endotherapy or not?
So what they possibly meant was that LSM above 25 are the patients who will have clinically significant portal hypertension, most likely above 12. And these are the patients, when you put in the scope, you'll be possibly observing red well signs or large varices. And again, banding is again a choice. So you might, if the patient is a non-bleeder, you might decide on a primary prophylaxis with a non-selective beta blocker rather than banding. So that's what I went through the literature of that, the reference of that, and that is what they meant, that these are the patients with more likely to have what we call as high risk varices.
Right. I think that's excellent. I have, again, an interesting point. Do you use the splenic stiffness measurement in your practice?
No, absolutely not. We don't have that.
Yeah. So I think we have, in some centers started very limited, but I think it's something which is evolving, and especially, in Indian setup, again, we need to validate our own data. I think it's really time that we have to have our own, good data on this LSM measurement. And I think it's an extremely useful tool. It's changing practice, and I think we need to do that. I don't see any question on chat box. Anybody, Amrita, you are free to, put in anything you want to ask at this stage, or put in before you speak for your next lecture. But one thing I'd like to ask you, Mithun, which I find this is an interesting term. We all know recompensation, which is something very interesting. What is your thought of recompensation versus reversal? You think that now recompensation is possible? We all agree to that. You think that the term reversal will also come in the next 3-4 years? We'll say, okay, there's a reversal of disease. Are you using that?
Sometimes we see actually. So to be practical, we see sometimes in OPD with an LSM of 25 last time. He comes after one. He disappeared from my chamber for last 2 years. And I ask him why. I start scolding him that why were you not coming? You need 6 monthly follow-up and all those things. And then I repeat, I come and go and get the repeat scan, and it comes as 8.2.
Yes.
So actually this exact thing we were discussing today in the hospital, that we don't know what to tell this patient, because last time I gave him a lecture that cirrhosis is irreversible. We can only maintain you in child day status and all those things. And we do see an occasional patients where, and that is possibly the etiology control, I think, particularly in the viral cases. And alcoholics, particularly, sometimes once we give up alcohol, we just forget they don't look like cirrhotics at all.
So absolutely, I think this is something which I'm very keen to develop. And I have many patients, whom somebody had told a transplant 10 years back, he will still come to OPD, happily, with a very graceful walk, and doing well. So I think that it's time maybe reversal term should also come, in our algorithm in the future. Anybody has any input at this stage before we move to the next talk? Yes, Hemlata, please.
So I can add
You
few
muted,
points.
yeah.
Yeah, so I can add some few points. So this transient elastography, as Mithun was saying, and you were saying, I don't think so. We are never ever going to give up endoscopy, especially if somebody comes with a, cirrhosis. But then the LSM becomes very useful, especially in alcoholics. So we see sometimes we see grade 2 varices, and they give up alcohol. You come back and do the LSM after 6 months. What was 18 or so will come down to 14. One is that. Second, this becomes a very important tool to, especially with the NAFLD. Like if you see something around 12 or 13, it becomes a very convincing tool for them to, to follow the lifestyle measures that, you're just going to touch there. Whether, so you may still be on the reversible part. So for, I think as a gastro or a hepatology practice, we are not going to give up endoscopy, but I think we can project the disease for an individual patient with that LSM. I think that we are going to use probably more and more, and maybe the diabetologists or general physicians may start using it in the future, probably.
I mean, I absolutely agree with you. I mean, this is true. And nevertheless, it's important, LSM is very important tool, and it's adding on to our practice. And I think that, such additional things which come, because, liver biopsy has a huge limitation, whatever you say, and HVPG, I think you want to speak on that. That also is not so straightforward, whatever you may say. So I think such tools are extremely important, and I think that it has a value. So I think with that, we will close this talk. Mithun, wonderful talk. Absolutely thankful to you for this, nice deliberation. And I would request you to stay on if possible.
Yeah.
And we can move on to the next talk by Dr. Hemlata. She will speak on LSM stroke UAP evolution, the evaluation of subclinical portal hypertension, non-cirrhotic NFLD. I think it's a very difficult topic. When I was reading this heading, I realized it's a tough job for him to speak on this, and it's a very good topic to dwell on. And I would invite you to make your presentation, Hemlata. Thank you.
Thank you, sir. Thank you, sir, for the kind introduction. I thank Hisky for giving us this opportunity to talk on this very interesting topic. So, so the topic which was given was, slightly bigger, that is LSM, UAP, evaluation of subclinical portal hypertension in non-cirrhotic NAFLD. But this is a very conceptual topic, and this concept as such is evolving, and we still need more validated studies. So I will first dwell on the basic concepts before going for a possible evaluation and if and how it is possible. So, so we all know the stages of fibrosis, and so the cirrhosis, wherein there is septal fibrosis and nodular formation, and there is a disorganized architecture, so which is the main driver for the portal hypertension in cirrhosis. So we all know the natural history of cirrhosis, that there is a compensated state, there is a decompensated state, and then there is further complication. And the main driver for all these events is the portal hypertension. And the portal hypertension is from the fibrosis. So we all know in NAFLD studies, so even though it is the steatohepatitis or the inflammation which causes fibrosis, but there are enough studies to show that it is the fibrosis stage which predicts mortality or time to develop severe disease. So if somebody is in F0 or F1, it may take more than 2 decades for any liver-related complication. Whereas if they are in advanced stage like F3 or an F4, they may develop a complication in a few years. So it is the fibrosis stage which is very important for the complications. Now coming to the topic proper. So this is a very good recent review article published around 2 months back. This exactly discusses the topic what we are going to talk. So one is, so the overlooked subclinical portal hypertension in non-cirrhotic NAFLD. So is it real and how to measure it? I think this sums up all. So that means, so whenever we say portal hypertension, we are talking about fibrosis or cirrhosis, but here we are going to talk about a subclinical portal hypertension in non-cirrhotic NAFLD. And this is not non-cirrhotic portal hypertension, which is a pre-sinusoidal portal hypertension. So first of all, let's go to how to assess the portal hypertension. So we know that, as of now, the best tool we have to measure the portal pressure, we have the non-invasive methods, yes, but the best tool as of now, which we have to measure the portal pressure is the HVPG, that is hepatic venous pressure gradient. So we know that basically we put in a catheter to the jugular vein, we enter one of the hepatic veins, we wedge but there is a balloon which is inflated and we wedge it. And what it measures is a portal pressure over an area. And the concept is that there is a static column of blood between the hepatic vein and the portal vein. So this wedged pressure is a surrogate marker for the portal pressure. So basically, this would work only in a sinusoidal cause of portal hypertension, and cirrhosis from most of the etiologies like HCV, alcohol, fatty liver, hepatitis B. So most of them is a sinusoidal portal hypertension. So that is why we are using HVPG whenever it is available to measure the portal pressure. And we have looked at the definitions of portal hypertension with the HVPG. So less than 5 is normal, and between 6 and 9 is what we call as the subclinical, and more than 10 is called as a clinically significant portal hypertension. So we have seen now lots of talk about, in the Baveno, what Dr. Mithun was talking. So HVPG is the marker for portal hypertension, and we are using LSM to compare that with the fibrosis or the portal hypertension. So what are the challenges in detecting portal hypertension in NAFLD? So HVPG is a relatively accurate measure of the portal pressures in HCV or with alcoholic liver disease, but not so with NAFLD. The exact reason is not so, but there are many studies which has looked into it. So this is one study published in 2017, and what they have seen is they have taken around 142 patients with cirrhosis. Around 25% is with HCV on the NASH, and for each stage of fibrosis, patients with NASH had a lower HVPG, and this could be possibly because this HVPG underestimates the pressures. So even in higher levels of fibrosis, it is more accurate when the HCV or the alcoholic liver disease patients. This is another study which is published more recently, so last year. So even though this was published last year, this is a study from 2 or 3 centers in France, and they have taken patients over almost a decade. So these are patients who had to undergo TIPS for various reasons, like ascites or bleed. And what they have seen that when they are doing the TIPS, they have tried to measure the wedged hepatic pressure as well as the portal pressure during at that same time. And what they have seen is that in NASH cirrhosis, the wedged hepatic pressure does not estimate portal pressure as accurately as in patients with alcohol or HCV-related cirrhosis. So this is because it underestimates the portal pressures. So exact reason why it is so, we do not know. So what we know now is that there are some challenges in HVPG in NAFLD. Now coming to the topic per se. So what is the evidence for portal hypertension in non-cirrhotic NAFLD? So we are talking about cirrhosis. What is the evidence for portal hypertension in non-cirrhotic NAFLD? So there are some studies which have been going on for more than a decade before. So here what they have taken, this was published more than a decade ago. So what they have taken is they have taken NAFLD patients and they have measured the HVPG. So around 50 patients were taken, and they were just having non-alcoholic fatty liver disease. So the HVPG was normal in about 50%. It was around 5 in another quarter patients, and it was elevated in around 28%. So what they saw was in the biopsy, around 9 of these 14 patients had no fibrosis. And only thing which was independently predicting portal hypertension was the degree of steatosis. So even in the absence of significant fibrosis, portal hypertension may be there if the steatosis is severe. This is another study which was published a few years later. It also looks at what are the prevalence and indicators of portal hypertension in patients with non-alcoholic fatty liver disease. So basically what it has done is around 354 patients with NAFLD they have taken, and around 100 patients had portal hypertension at the time of diagnosis. Secondly, they have looked at the patients who had little fibrosis, that means F1 or F2 fibrosis. Around 200 of them had very little fibrosis. Even in them, around 6%, around that is 12 patients had portal hypertension. It was not a very high, like more than 10 or 12, but it was between 6 and 10. And all these patients had significantly higher steatosis. This is also another study. Now, this was published recently. So what this is doing is that the main aim of the study, main conclusion of this study is also that patients may have signs of advanced liver disease and clinically significant portal hypertension, but they do not necessarily have cirrhosis. So this also almost similar findings. Around 14 of 89 patients had no histological features of cirrhosis. Still among that 14, around 7 had F3, the rest of them had F0, F1. So one argument we can put forward in all of these studies is that we know there are problems with the liver biopsy also. So there is HUPG and they're comparing it with liver biopsy. So we know that liver biopsy can be segmental, that can be sampling error. So it could be possible in most of the studies, but this particular study took care of that. So they made sure that the sample size and the portal triads, everything was adequate, and they tried to take care of that. So, and in this, they have noted that there is a perisinusoidal fibrosis alone was there. There's no septal fibrosis. Perisinusoidal fibrosis was there in most of the patients. And most of them had NASH as the etiology. So what we have now seen so far is that there are challenges in HUPG measurement in patients with NAFLD. There is evidence of portal hypertension with just steatosis alone, even before fibrosis or at least advanced fibrosis occurs. So is the portal hypertension in NASH, is it different from other etiologies? So let's look at some of the pathophysiological features. So there are some experimental studies which have been done, and I will just bring forward 2 or 3 of them. So one was done long back in 2004. So they have given methionine choline deficient diet, which can induce fatty liver. And what they saw was that such sluggish sinusoidal flow was seen several weeks before the perisinusoidal fibrosis was evident. The second one is more recently, so wherein the rats are fed with this so-called cafeteria diet, that the diet which is rich in carbohydrates and fat and sugar. And what they saw was that after 8 weeks, diffuse steatosis, ballooning or lobular inflammation and portal pressure were present even before the presence of significant fibrosis. So there is some experimental evidence is there. And what we know now is that the increase of portal pressure is already present in patients with NAFL, even in the absence of inflammation and fibrosis. So these concepts are all evolving, and we definitely need more studies to prove all of this. But we know that just steatosis alone can increase some amount of portal pressure. The second, this probably we need to put more thought, is that the cause-effect relationship between liver fibrosis and portal pressure. So, it's not always unidirectional. That means we know that increase in fibrosis means increase in portal pressure, so portal hypertension. But then it can also be that there can be an increase in portal pressure, which can induce more inflammation and fibrosis. So it can be bidirectional. So this is one cartoon which I've taken from Schlesinger. So this is the normal liver histology. So you have the hepatocytes, and then you have the sinusoids, which are lined by the endothelial cells, and there are lots of fenestrae, that means holes in between. And then there is the space of Hisky, where you have the hepatic stellate cell. So this hepatic stellate cell, in a normal time, it is very quiet. But once there is some injury, and then the progressive injury is there, you develop cirrhosis. So what happens in cirrhosis is that there is an activation of hepatic stellate cell, and there is this deposition of collagen in the space of Hisky. And so the sinusoids are distorted, the fenestrae are closed, and then these sinusoids are constricted. So there is portal hypertension. So this is how it is the normal way a liver injury progresses to fibrosis and cirrhosis. But what happens in NAFLD? So the stop cartoon. So this is almost same as the previous one. So you know that there is the portal triad here, and then from there the blood flows to the central vein. So there are hepatocytes, there are sinusoids, there are Kupffer cells, and there are stellate cells. When there is fatty deposition in the hepatocytes, so what happens is that these lipid-laden hepatocytes, so that by itself can narrow the sinusoidal space, so by as much as 50%. The second, once these cells are loaded with fat, this can induce what we call as lipotoxicity, and it can induce ballooning. So the ballooned cells can further reduce the size of the sinusoids. So there is a sinusoidal compression and there is an elevated intrahepatic vascular resistance. So when there is compression and there is elevated IHBR, so then all the next cascades gets activated. So that means the endothelial cells are activated. There are lots of cell adhesion molecules coming, lots of cytokines coming, and then there is, the collagen deposits. There is no angiogenesis. So all those further subsequent things start happening. So even though initially it could be just be a decrease in size of sinusoids, it may trigger further downstream complications of inflammation and fibrosis. So we have seen that possible pathophysiology of this subclinical portal hypertension. So now how do we measure this? So whatever studies I have quoted is that they have looked at patients of NAFLD in general, and they have looked at the the clinical picture of portal hypertension, and they have compared it with HCPG and the liver biopsy. So is there any other way to do it? So now the thing which we have, like we see the pitfalls with HCPG, we know the pitfalls with the liver biopsy. So now the transient elastography has come here to stay, and then we looked in detail now with what Dr. Mithun talked, how it can diagnose portal hypertension, and it is a reliable technique. But we have to remember that these non-invasive methods have been developed to predict the extent of liver fibrosis. But what we are now talking about is that can it detect portal hypertension without cirrhosis? Especially when it is low. So no, we really do not know. We do not have much studies on these non-invasive methods, or at least LSM, to detect the subclinical portal hypertension. Actually, I tried, but I could not find much. What we have is all the studies from various NAFLD, HCPG, and LSM. And some novel methods have been proposed. So one is this, using this contrast enhanced ultrasonography. So where they use this, air bubbles, encapsulated air bubbles. So when that is pushed, they have something called a subharmonic aided pressure estimation. So there is this air contrast will go into the blood vessels, and based on the behavior of the surrounding liver tissue, it can estimate the actual portal pressure. So it is not freely available. I'm not sure whether AIG is using it, but I am not familiar with this technology yet. But probably more, we are likely to maybe use the next technique, that is US guided direct portal pressure measurements. We are probably likely to use this more in the future. So we know that the HCPG we go through the hepatic veins, and we measure through the sinusoidal pressure equalization, whereas in US we can go through to measure the pressure in the hepatic vein as well as in the portal vein. So this, when we measure the portal vein pressure directly, so we may have much more reliable methods. We still need more studies on this, actually. Okay, so we know that subclinical portal hypertension can exist even in those without cirrhotics. So now, okay, so what is the use? So everything has to be having some kind of either a prognostic or a therapeutic perspective. This probably we have to wait and see. We already know that statins have been studied, especially simvastatin, and what we know is that when we give simvastatin, they have seen that it brings down the hepatic vascular resistance. So suppose, so in an established case of cirrhosis, maybe it may not be useful, but in the subclinical stages, where it is there is still a dynamic component. So whether simvastatin or other vasodilator drugs can play a role, we'll have to wait and see. So I have come to the end of this talk. And so my main summary is that this, whatever I've expressed, is more of conceptual. So what we know is that portal hypertension, even though it can be subclinical, can develop in non-cirrhotic NAFLD. This elevated intrahepatic vascular resistance can occur with steatosis alone. And here the sinusoidal space is narrowed by the steatotic hepatocytes, and there is a shear stress and there is an endothelial dysfunction. And this increase in sinusoidal pressure can further propagate, the liver cell injury, inflammation, angiogenesis, and fibrosis. We still need more methods to exactly measure the portal pressure in this kind of patients. Thank you for hearing me.
Thank you, Dr. Hemamala. That's again a very nice presentation. Of course, there are many unanswered issues at this stage, because this is the evolving field. I mean, to firstly conceptualize subclinical portal hypertension. Now, this is a term which is in itself is very, like you can striking. What is it? What are we going to talk about? I mean, the question is like, you think that that we can halt the disease at a stage of subclinical portal hypertension when it has not even manifested? Well, that would be the ideal thing to do. Secondly, entire thing, I think we are looking at NAFLD today. Your talk is in that, and LSM. We come to that. So if you can just elaborate once again, because that's what the important thing as a concept. How does a fatty cell, a hepatocyte which is laden with fat, a solent hepatocyte? So what are fundamental, you have already mentioned, but I would just like for the clarification for the audience once again, what do you think are the most important factors which contribute to an evolution of portal hypertension in a fat-laden hepatocyte? Among the various things you have told, what are the most important ones?
So one is the degree of steatosis as such. So that itself will trigger. The second is there is always a kind of inflammation. Now, what triggers the inflammation? We are not sure. It could be some kind of gut microbiota. We don't know. It could be some kind of cytokines. Why some people have increased inflammation, we are not sure. But once that inflammation is triggered, there is injury, there is fibrosis, and then the portal hypertension. So if we can if you have to intervene, yes, first is the deposition of fat itself, we have to intervene. The second is the inflammatory component. If we can put a halt by some method, either the gut microbiota or various drugs have been tried, but still we still do not have so many trials in the last few years, I think, but none have really shown a beneficial clinical effect in the reversal of NASH, I think so. But still, if we can prevent the deposition of fat itself, that's the best part, and then the inflammation part.
So am I right when I say that a person who's got 10% fat in liver versus somebody who's got 60% fat in liver, the greater the fat, the greater is the chance of portal hypertension? Is it true?
So that's what this concept seems to be evolving. One. The second, so now how to quantify the fat was, we can probably use the UAP or the CAP for that, quantify the fat non-invasively or by biopsy, and then we'll have to see it. But what is known as of now is that when we look at clinical endpoints, that is decompensation and complication, it still correlates only with the fibrosis. That's what we know, but that is at least known for sure. So we need more evidence to, from this conceptualize what we are talking. Yes, probably 60% fat at one point. If it continues to be like that, it is probably going to lead to more liver injury than a 10% fat.
And also in the same flow, would microvesicular versus macrovesicular fat, would it make a difference in your thought?
Yes, it is likely, because microvesicular fat, the cell may not be enlarged, but macrovesicular fat, the cell will be enlarged. So so definitely, so it is likely to cause more injury. So
right. I think that's what I also feel that macrovesicular would probably be more more of a concern, and we see, but because we value these donors for transplant, day in and day out, and we are doing all sort of measurements which we can, MR based biopsy, CT scan, LA and all. And I see that this fat story is one thing which is ever confusing. I mean, every time you see something happening and surgeons say, come on, yeah, ignore, let's go ahead. So, but I think this is a very evolving field, and I would feel that there are a lot more data which is needed. There also, because this is the right time to discuss this. You did mention about, HVPG measurement, even endoscope, US guided tools. So that is something which we also have to understand. Are we any better in measurement of portal hypertension? You can measure blood pressure directly, with a cuff. We all know that, we understand that. But in portal hypertension, the last 2-3 decades, which I have seen, we have not advanced in a big way. We are still relying on indirect methods. So what are your thoughts on advancements in measurement now and in future about measuring the portal pressure? Mithun, you can join in too if you are around.
I think a new field like called as endohepatology is going to come, so.
I just read, I saw in your slide, so I thought I will put it in this question, the endohepatology. I like that term.
So it is going to come, but I don't know who's, so it's basically maybe the, the HCPG, this EUS measured, portal pressures and all those interventions. So I think it's going to come. We will be evolving into that. Again, the cost and all those kinds, but so I have seen clinical, I don't know, maybe you can give it. There are some patients with NASH who will come with bleed. And then once that bleed is taken care of, they will remain, at least their bilirubin will remain at 1, the INR will remain at 1.2, albumin will remain at 4 for years together. There are one group of patients, so they have a more of this portal hypertension component than the hepatocellular component. Maybe, in those patients, we have not measured HCPG because we just think it's more invasive and, it is more costly. We don't go ahead and honestly puncture. But maybe if you study those kind of patients, this would probably make more difference. And maybe it will, just like it is not NCPF. Definitely, it is not a non-cirrhotic portal hypertension, that traditional term. But maybe at least those patients may live longer sometimes.
Yeah, I think that's important, because I think I agree with you, and because you had this UAP also in your talk as a part. I mean, do you think there's control attenuated parameter which we see in these FibroScan machines and all? Does it quantify the fat? Like you have 200, 250, 300 values which we see in our OPD practice. So how closely it actually quantifies the fat in your thought in the clinical setting?
So I think the accuracy for this UAP or CAP is around 60-70%, I think so. But and also depends on the BMI, even though we have different, even if we have a different probes. But we are not able to give that much accuracy as much on the stiffness alone, stiffness and the fibrosis correlation. But yes, definitely around 60-70% accuracy is there for UAP or CAP for the steatosis content. And so like suppose somebody has a 300 of UAP or CAP. So obviously he has around 60% steatosis. And then we can just use that as a guide to counsel for lifestyle measures. But whether we can really use that to diagnose portal hypertension or at least subclinical portal hypertension. Now, maybe after reading these topics, I can only tell them that you better be watchful in your weight, that you may, even though like suppose we see sometimes, UAP or CAP is around 270 or 280, but stiffness is still around 6 or 7. Young people, they are usually relatively young, not the older ones. Older ones will have higher stiffness, younger ones. So we say that your stiffness is going to increase over the next few years if you don't bring down this fat.
Yeah, I mean, I think that's perhaps absolutely the right thing to counsel your patients, and I agree with that. We are nearly, coming to the end of the session. Mithun, do you have anything to add to what we have discussed today?
Yeah. So basically, the two just small comments regarding the portal hypertension in NAFL. I feel NAFL is a multi-system disorder. So the concept that is coming up is that the amount of endothelial dysfunction, be it inside the liver, be it inside the arteries of the heart, is far more in patients with NAFL than with any other cause of cirrhosis. So this endothelial dysfunction is much more in NAFL, and so this possibly leads to more of decreased sensitivity to the vasodilatations inside the liver. So that is one concept that is coming up, while the portal hypertension may be more, despite a lower HBPD, it might be at the very small vascular levels. And studies have shown that there are a lot of microthrombi in patients of NAFL, the liver. So that is one concept. Coming to endohepatology, yes, we have already started using this terminology. So we are just on the verge of publishing a paper where we have around 100 patients of US guided liver biopsy from left and right lobe, because left lobe is technically easier to biopsy, and whether it's the same. So, and the US portal pressure is, the device is not yet approved by the DCGI. So despite trying to get the device, we are not able to use it at this point of time. But that is a very interesting device that is coming up.
Wonderful. So I think we had a very exciting, 2 talks and a couple of new things, and the endohepatology term, which has been probably shared in the forum, really in a serious way for the first time in my thought. I think it's something which is interesting and evolving, and I think clearly that all these newer modalities are going to be complementary to each other. LSM has its own value, UFA has its own value. We all agree to that. There are further refinements, improvements coming up, and we have to understand that we all agree that doing a biopsy or HPG straightway is not so simple. But yes, any non-invasive tool which is there to my mind, which helps us to develop a guideline for us from clinical perspective, I think that is more than welcome, and I really look forward to that. So I would thank the organizers, Lai and the team, for giving us this opportunity for this different type of a webinar. 2 very good talks, both clinical as well as basics have been covered very well. And personally, I have been, enlightened. I have myself learned a lot from these. And I would thank from my side both the speakers, Dr. Mithun Sharma and Dr. Hema Mala, for brilliant presentations and some excellent discussion. And I'll hand it over to Lai for her comments. Thank you very much.